So all set, we'll start?
Yep.
Yeah. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 12G Respiratory System. And we are streaming live from UHS Southampton, UK via Kolkata. And we have, before I start off, let me introduce the topic, which is interstitial lung disease. And before I introduce the speaker, let me introduce the moderator. The moderator is a very special person, Dr. Sridevi Sitharaman. She is a postgraduate from PGI Chandigarh, a DNB and an MA in bioethics, a consultant pathologist in Vivekanand Memorial Hospital, and she's also a consultant in Sigma Hospital, Mysore. Studied in PGI MD pathology from 1994 to 96, followed by 2 years of senior residency. Did a fellowship in HIV medicine from University of Florida, USA. She did a master's in bioethics from Belgium. Inspired by the notion of social concern and nation building of Swami Vivekanand, she was involved in the last 30 years with an NGO called Swami Vivekanand Youth Movement, located in Mysore, Karnataka. She has special interest in laboratory medicine, quality control, palliative care, medical ethics and research. A very special person. And let me now ask her to introduce the speaker and to take it up from there. Dr. Sridevi, all yours, please.
Yeah, thank you, Dr. Nadeem, and thank you for the opportunity to be on this program. It's a joy and a privilege to introduce to all of you Dr. Sanjay Jogai. Dr. Sanjay Jogai, I've known him for more than 20 years now. Both of us were at PGI Chandigarh. Dr. Jogai did his MD in pathology from Chandigarh and also his senior residency there. And later on moved to the UK, where after his FRCPath, he's been working as a consultant histopathologist at the University Hospitals of Southampton, which are part of the NHS Foundation Trust in the UK. So Sanjay is right now in Southampton. It's a chilly 1 degree centigrade in the middle of the afternoon. I'm sitting here in Mysore, a balmy 24 degrees centigrade. So it's great that we're all able to meet from such diverse geographical locations on one platform as part of this online webinar. Sanjay has been practicing histopathology for close to 2 decades now. His areas of interest are pulmonology, lymphoreticular malignancies, and his special interest is in the interstitial lung disease. That's the main reason why he is giving this talk. So Dr. Sanjay will be conducting this seminar as a series of case studies. They're all real life stories, real life cases from his own practice. So I think it's going to be very interesting for us to see how pathology plays out in real life. Interstitial lung disease, as you all know, is a very complex thing where everything sounds same, everything looks kind of similar, but there are some subtle things which really clinch the issues for us. So when you look at it in the background of case studies, it becomes more interesting and clinically relevant to all of us. So with this, I hand over the platform to Dr. Jogai. Please.
Right, we are live on YouTube. So you just press present now, please. Your entire screen. And press in the center and share. Great. Yeah, we can see your screen.
Okay. First of all, thank you very much, Dr. Nadeem, for inviting me. It's a real privilege and honor to be part of this forum. Thank you very much, Dr. Sridevi, for the kind words. It goes back a long time, and you were a very admirable senior when I was a junior resident in pathology at PGI. At this stage, I would also like to thank all my teachers, my seniors, my batchmates, as well as my juniors back in PGI. To a great extent, what I am today is they've all played a big part in that. So without much ado, I'll go ahead and start my talk. So basically, the outline of my talk is just a second. So I'll be, can you see me? Can you see the slides?
see you, but we can see half your screen again and half on the video, like it was earlier.
Okay.
We can bring it back to the full screen like it was earlier.
Can you see now?
Now we can see nothing.
Okay, that's a bit of a...
No issues, take your time, no problem. Right, it's back to where it was, half of video and half of the screen.
Now?
Yeah, now it's better, at least we are seeing the screen, but you can continue with this, it's perfectly fine.
Okay, thank you very much. So what I've done is, the outline of the talk is basic definitions about the various entities and the classification, a bit of historical perspective, then describing various entities. Now, rather than describing all the esoteric examples, I have focused on the main entities, which include UIP, which is usual interstitial pneumonia, non-specific interstitial pneumonia, and then extrinsic allergic alveolitis, also known as hypersensitivity pneumonitis. A discussion about the importance of multidisciplinary team in the diagnosis of interstitial lung diseases, and then the more interesting part, which is routine practice cases which I have seen in the last 10-12 years or so, and towards the end describing a few miscellaneous entities. So first 10 minutes or so would sound a bit theoretical, so please bear with me. So when we come to idiopathic interstitial pneumonias, way back in 1975, Avery Liebau proposed the original classification, where he said basically there are 5 things: usual interstitial pneumonia, bronchiolitis with interstitial pneumonia, desquamative interstitial pneumonia, lymphoid interstitial pneumonia, and giant cell interstitial pneumonia. About 23 years later, Anna Louise Katzenstein and Jeffrey Myers came up in 1998, and they said, hang on a minute, let us eliminate LIP, because LIP is basically a lymphoproliferative disease, so we should not be having this in the classification. They also said we should eliminate BOOP. BOOP is basically bronchiolitis obliterans with organizing pneumonia, because the pathology is mainly intraluminal rather than interstitial. And what they did was they added acute interstitial pneumonia and non-specific interstitial pneumonia. Fast forward, and we have various important publications. In the meantime, for those who are interested, there are 3 in particular. This one talks about the International Multidisciplinary Classification of IIPs, and the more recent one in 2018, which is basically the executive summary of diagnosis of idiopathic pulmonary fibrosis. Now, in the revised American Thoracic Society and European Respiratory Society classification, they basically say that there are 2 broad categories. One is the rare, which we don't see many, and the common ones are the major idiopathic interstitial pneumonias. And there are 5. First is idiopathic pulmonary fibrosis, then we have idiopathic NSIP, then respiratory bronchiolitis with ILD pattern, DIP, which is desquamative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. Now, this is an important slide because it basically groups the entire interstitial pneumonia patterns into 3 broad categories based on the clinical, radiologic, and pathological diagnosis. So within the chronic fibrosing interstitial pneumonias, you have idiopathic pulmonary fibrosis and idiopathic NSIP. Smoking-related interstitial pneumonias, you have the respiratory bronchiolitis interstitial lung disease, as well as desquamative interstitial pneumonia. And within the acute and subacute interstitial pneumonia pattern, you have COP or cryptogenic organizing pneumonia, and acute interstitial pneumonia. Now, the associated radiologic or pathologic morphologic patterns are quite, they stay the same as name, except that IPF, in pathology, we get a pattern which is known as usual interstitial pneumonia. Idiopathic NSIP stays the same as NSIP. RBILD, as a pathology counterpart, we find respiratory bronchiolitis. DIP stays the same as DIP. COP becomes organizing pneumonia, and the counterpart of acute interstitial pneumonia is diffuse alveolar damage pattern. I'll be showing you slides on these cases, so it will make it much clearer. Now, one aspect that came up in the classification meeting of the ATS ERS was there is a small subset of cases which remain unclassifiable despite extensive workup, whether it's based on clinical, radiological, or pathological examination. And some of the key findings of that were that you may have inadequate clinical information. For example, a case may be referred from some other hospital. You may not have adequate radiologic data, or the biopsy itself may not be entirely representative or may be small to interpret. The other major issue is there is a major discrepancy between the clinical, radiologic, and pathologic findings, and that's where the importance of interstitial lung disease MDT comes to play, and I'll talk more about it in a few minutes. The other thing is the effect of previous therapy. Could that result in alteration of radiologic or histologic findings? A typical example would be if a patient is breathless and in the interim has been treated with steroids and then undergoes a biopsy. Clearly, the inflammatory component could be dumbed down because of the steroids, and you may see a slightly altered morphology, which may not help you reaching the correct diagnosis. The other very important issue is that sometimes you get different pathologic findings in different lobes, and it may be difficult to tie it up with the clinical and radiologic data. So these, broadly speaking, would come under an unclassifiable interstitial pneumonia pattern. Then the decision obviously rests with the chest physician to determine, based on taking into account the clinical, imaging, and the pathology findings, how to proceed with the case. So the executive summary of those articles was that idiopathic NSIP is a specific clinical pathologic entity. Clinical progression is rather heterogeneous. With regards to smoking-related ILD, they saw that new information was forthcoming. For example, RBILD was increasingly being diagnosed without biopsy in smokers because on HRCT, one could see ground glass opacities and centrilobular nodules, and bronchial lavage also played a very important role because you could see lots of smokers' macrophages and no lymphocytosis. So smoking-related ILD was better defined. The other issue was natural progression of IPF is very heterogeneous. So you have a group of patients who can be rather stable. Some could be having a rapid and steady progression, and a minority of cases you could see acute exacerbation. I'll show you a couple of examples from practice on this particular entity. Then coming to acute exacerbation within the chronic fibrosing interstitial pneumonias. This is much more common in IPF and NSIP compared to other diseases such as RBILD or EAA. Some patients are difficult to classify, i.e. you see mixed patterns of lung injury. So in one lobe you could be seeing like sarcoid-like granulomas, in the other you could be seeing organizing pneumonia. Now how do you come to a conclusion? And then the field of emerging molecular markers. Now this is something crucial. How do we agree with each other when it comes to interstitial lung disease? It's quite a niche area with experience having a major role to play. Now, when I say experience, it's not just the pathologist who is experienced here. It is seen that in early series, the observer agreement was marginal among clinicians, radiologists, and pathologists, because say 20, 30 years ago, for example, a chest physician would be doing 5, 6 different things. Now, what we have is For example, in my own hospital, the chest physician just dedicated to interstitial lung disease, for example. Another chest physician just doing neoplastic lung pathology. Another doing, say, for example, COPD. So that is making a lot of difference. What is also happening is we have better HRCT. So the people who are interpreting those scans are more experienced. Now, what has been seen is if ILD, interstitial lung diseases, are discussed in an academic setting where you have dedicated radiologists and pulmonologists and pathologists, the diagnostic agreement is much more. So that's very important now. Now, with that, I'll come to what are the different problems or differential diagnosis considerations when we are talking about idiopathic interstitial pneumonias. Now, starting with hypersensitivity pneumonitis, in the past 10 years or so, the clinical HRCT and pathologic features of chronic HP have been more sharply defined, i.e., when it comes to imaging, on HRCT, you tend to see centrilobular nodules, mosaic air trapping, and upper lobe distribution. So this is very important. So as a pathologist, when you are told that information, it is very crucial. And on biopsy, what you tend to see is a very bronchiolocentric distribution of inflammation and poorly formed granulomas. I'll show you a few examples in a few minutes. What is very crucial with HP is that a detailed search for a potential exposure is very much essential. So sometimes you will come across patients in the clinic who won't be very forthcoming with the history. As a clinician, as a physician, one has to really dig deep, finding all the pertinent information as far as exposure is concerned. It's not just birds that cause hypersensitivity pneumonitis. Unfortunately, up to 30% of patients still do not have any identifiable exposure. And that is a bit frustrating, but taking into account the pathology findings as well as the HRCT and the clinical, the clinician is usually happy to go ahead and treat the patient as HP. Then coming to collagen vascular disease, one should remember this, that it's a very frequent cause of interstitial pneumonias. It usually presents with an NSIB pattern. Again, I'll show you a few examples. With collagen vascular disease, it's very important that the clinical, serologic, and HRCT as well as histologic features are taken together, because that's the key to arrive at a diagnosis. As a pathologist, one cannot offer a definitive diagnosis if you don't have the serological counterpart or a clinical counterpart of what you are seeing on histology. Your diagnosis is very much in isolation. Then the extent of serological evaluation is quite variable, by which I mean not all hospitals will have up-to-date antibody testing, and with each year there are more and more antibodies that are coming up for detection of collagen vascular disease. Coming to familial interstitial pneumonia, I must admit I do not have much experience because we don't see much familial interstitial pneumonia. This is from literature, so up to 2 to 20% of cases may have a familial component, and they show heterozygous mutations in SFTPC. And based on HRCT and lung biopsy alone, you won't be able to make out whether this is familial or not. What is very important is when taking a detailed history, the physician should always ask, does anybody in the family have any history of breathlessness or anything to do with any chest symptoms? The fourth important thing about the differential diagnosis is coexisting patterns, and this is very important. Now, luckily, in most patients, you can offer a single clinical, radiologic, and pathologic diagnosis, which basically encapsulates the whole disease condition. The crucial thing to remember is sometimes multiple patterns can exist, and that can confuse. For example, if you have VATS biopsy sent to you from 2 different lobes, and in one you are seeing a very clear-cut pattern of eosinophilic pneumonia, but in the other you have a UIP pattern. Similarly, you have sarcoid-like granulomas in one, whereas UIP in another. Or in smokers, you can have LCH in one focus with rest of the lung showing RB-ILD type pattern. Not all is lost. The important thing as a pathologist is to enumerate what are the patterns and what other information that you can include in the report. The most important thing here would be when the patient is discussed at the multidisciplinary team meeting, the clinician, the radiologist, and the pathologist will sit together, work on the different patterns, and whatever is the most clinically significant, that is how the patient will be treated. For example, if the patient had sarcoid-like granulomas in one biopsy, but UIP in the other, we all know UIP is a more aggressive condition, and the patient could be responding to antifibrotics. So rather than treating sarcoidosis as such, the clinician is likely to go after UIP because that is what is going to be a more of a killer condition. So coexistent patterns is important to remember. Now, that brings me to the concept of interstitial lung disease meeting. So I think this is one of the most interesting multidisciplinary team meetings that I attend in my areas of specialty, because compared to cancer, for example, where things are more black and white, either it is malignant, and if it is malignant, what is the type of malignancy, if it is benign, and that's it. ILD, what I feel, is very much a team game. A pathologist cannot sit in his or her ivory tower and offer a diagnosis outside of the context. So everything has to be linked together. So at my place of work, we have this as a fortnightly meeting, and it's in one room wherein we have the chest physician, who is basically dedicated to treating ILD cases, a thoracic radiologist who specializes in imaging on ILD patients, a thoracic pathologist, an ILD nurse specialist who is the liaison basically between the patients and the clinicians, and then the specialty registrar, by which I mean, for example, junior residents and senior residents in Indian context, because that's how they pick up their interests, and going forward they may be becoming consultants one day. Now, as I have said, clinical data. What is the presentation of the patient? Does the patient have any exposure history? Exposure as to exposure to birds, exposure to, for example, working in the farms to farm animals, any of that sort of thing. Working in, for example, metal industry or glass blowing factories, that sort of thing. For example, asbestos. I'll show you cases in a few minutes. And then smoking history. What are the lung functions like? Lab findings, very important. So serology, for example, to determine whether there is underlying connective tissue disease. And importantly, are there any coexistent diseases? So for example, the patient already has a history of rheumatoid arthritis or Sjogren syndrome, because people with those conditions could have lung diseases related to them. Now, what's interesting is, because there is no rush in these meetings and we have a dedicated time allocated to us, we take time rather than it becoming a tick box exercise. So every patient is discussed in detail. We bring back patients after a while, if they've responded to therapy or not. We review our diagnosis even. Sometimes we may not get it right. So we bring back the H&E slides. Okay, if the patient is not behaving as we had offered the diagnosis, is there an alternate there? So it's a very beautiful and very pragmatic way of doing clinical medicine, let's say that way. So in most cases, we can achieve a consensus diagnosis. Now, there is a side effect in some ways. As pathologists, we are always wanting more tissues. So what has happened is, because we have got such experienced chest physicians and chest radiologists, the number of biopsies that are being performed in cases has gone down. We recently did a 10-year audit, and we can see that in the last 3 to 4 years, the number of biopsies has gone down. And why is that? The HRCTs are so good, and the clinical findings together with serology, if they are able to arrive at a consensus diagnosis, in those cases, they won't be asking for a biopsy. So essentially, biopsies are performed where there is a clinical doubt. So for example, the imaging is showing features of NSIP, and the clinician thinks, could this be UIP? Because if it is UIP, they can be given the antifibrotic drugs, because there are specific rules as to who you can give those drugs. So in cases like that, if they ask for a biopsy and on histology you have a diagnosis of UIP, that would take them, lean the clinical diagnosis towards UIP, and the patient will be treated as a case of idiopathic pulmonary fibrosis. With that background, I'll now start the main entities. So starting with usual interstitial pneumonia, it's the most common of idiopathic pneumonias, usually has an insidious onset of dyspnea, often a chronic and progressive downhill course. Majority of the patients are 50 to 70-year-olds. Usually we almost have like a dictum in practice that tend not to diagnose UIP easily in a less than 60-year-old. Almost always when we go back to our patient demographics, we don't usually see UIP in a patient less than 60-year-old. Familial cases are described, I have seen only once, so my experience is pretty limited. Usually male is to female ratio is 2:1. Now coming to the diagnostic histological features. There are certain specific features which we are looking for when we are making a diagnosis of UIP. First of which is spatial variegation. Now, what do we mean by spatial variegation? When we pick up the slide, we see a patchwork pattern. So we see interstitial fibrosis, but it's not uniform. You see areas which are fibrotic. Bang next to them you have very normal looking lung parenchyma. So this patchwork pattern is very important. Second thing is architectural distortion. So you see interstitial scars, you see honeycomb change. I'll show all these in examples, so please bear with me for the time being. Then the single most important thing with UIP is temporal variegation. Now what do we mean by temporal variegation? This means that there is active ongoing fibrosis, which are basically fibroblastic foci, alternating with areas of inactive collagen type fibrosis. So when you look at a slide, you have well established areas of fibrosis. Bang next to them you have normal pattern lung parenchyma. Then next to that you have fibroblastic foci. So this is known as temporal variegation. Temporal variegation is one of the key findings of UIP. You may get fibroblastic foci in other conditions as well, but this pattern where you have very much fibrotic lung parenchyma, then normal, then fibroblastic foci is reasonably diagnostic of UIP. The other very important thing about UIP is inflammation is minimal. Most of the times you will see a lot of fibrosis with minimal inflammation. If you are seeing a lot of inflammation in something which otherwise looks like UIP, always raise the diagnosis of connective tissue disease, because connective tissue disease is one reason why you could be having prominent lymphoid infiltrate. Then what are these fibroblastic foci? So basically these represent microscopic zones of acute lung injury. They're randomly distributed within areas of interstitial collagen deposition, and basically they comprise of fibroblasts and myofibroblasts, which are arranged in a very pale staining matrix. I'll show you some nice examples in a few minutes. Now, what is the pathogenesis of UIP? There are several theories around. We did a very detailed examination of several cases by studying, by actually undertaking micro CT scanning the paraffin blocks. I think that's outside the remit of this talk, so I'll stop short of that. But the basic features are there is abnormal wound healing, there is decreased apoptosis of myofibroblasts. That's why you get more myofibroblasts, and there are more fibrogenic cytokine, that there is more response to the fibrogenic cytokines, and obviously an imbalance between the synthesis and degradation of ECM and aberrant angiogenesis. So a host of factors playing a role in the pathogenesis of UIP, IPF. Now, as a pathologist, there are a few differential diagnoses that one has to consider. First of which is the fibrosing variant of NSIP. Now, this won't be easy in all cases, So one can only go as far as is possible. So for example, if you're seeing clear-cut fibroblastic fossa in an otherwise very fibrotic looking end-stage looking lung, you would say that it is end-stage UIP. Now, the reason why it is important to distinguish the two is fibrotic NSIP often responds better to corticosteroids compared to UIP, which would respond better to antifibrotics. The second differential would be BOOP, which is basically bronchiolitis obliterans with organizing pneumonia. The crucial thing with this is it's mainly an intraluminal proliferation rather than interstitial. So that's another key. The third DD is extrinsic allergic alveolitis. Now, a key point here is you can see a fibroblastic foci in EAA, but the mere presence of fibroblastic foci should not lead you towards a diagnosis of EAA because the pattern of inflammation is very striking. In EAA, you typically get a bronchiolocentric inflammation and granulomas would be there. So if on a lung biopsy you are seeing granulomas, you are reasonably sure of all things possible, it's definitely not going to be UIP or NSIP because those conditions don't show granulomas. With that theoretical aspect behind us, we are nearly 15 minutes half an hour into it. We'll now do the cases. So this is from a few years ago. Miss LMC, she was a 62-year-old female, had a 1-year history of dry cough, but there was no hemoptysis. She had dyspnea on exertion. She was a non-smoker and had been off work, previously having worked as a carer. Important family history. Her sister had tuberculosis and brother had died of asbestosis. Anyway, cutting the long story short, she underwent a CT scan. The CT scan reported it as a fibrotic NSIP. I don't have the pictures, unfortunately. And a VATS biopsy was performed. For the trainees, VATS is basically video-assisted thoracoscopic surgery. That's how we get most of our biopsies. So these are all video-assisted biopsies. Now, this is a low magnification of the VATS biopsy. So going back to a few slides ago when I talked about UIP patterns. So that's what I would like to emphasize here. So look at this area of lung parenchyma, reasonably normally aerated. And then you have these subpleural areas looking quite pink. Look at this broad swathe of collagen-like tissue, possible some honeycombing. So what I'm trying to say here is you have normalish lung parenchyma with subpleural scarring, paraseptal, quite advanced scar extending from the subpleural region to the deeper lung parenchyma. So very scanner view, and gives you an idea basically that you are dealing with probably a temporally heterogeneous process where you have established fibrosis with normal appearing lung parenchyma. Nothing more that we can see on this power. So we'll go to the next slide. On a higher magnification, the subpleural fibrosis is enhanced. You can see quite pink, and the honeycombing starts becoming prominent. On a further high power, you can see microscopic honeycombing with reasonably established fibrosis, very pink lung. This is not normal at all. We are not supposed to have lungs like that. And while we are looking around, we suddenly come across areas like this. And this is what I was wanting to emphasize when I was talking about fibroblastic foci. Now, let me bring it up on a slightly higher magnification. And this is what is a fibroblastic focus. So you see this almost like a nubbin of tissue, which is covered by a thin layer of epithelium. And you have spindle-shaped fibroblasts, myofibroblasts, arranged in a very loose sort of myxoid matrix. Now, it's very crucial that this is not confused with what you see in organizing pneumonia, for example, which is intraalveolar. This is embedded within the wall. Let me show you a few more. So this is another beautiful area. You can see some microscopic honeycombing here, a bit of mucoid secretions within the bronchiole, and a beautiful fibroblastic focus. Look at that epithelial overlying it and these spindle-shaped fibroblastic cells. Another focus. So usually what happens is they are parallelly arranged to the epithelium and the stroma is a bit loose. Now what is interesting here, if you have noticed, there is quite a bit of inflammation. So in my talk earlier, I emphasized that UIP usually does not have inflammation. So why do we have that? So that is something to bear in mind, that we are seeing a bit of inflammation here. This is another area, and you can clearly see that lymphoid aggregates. So as a pathologist, that's a bit perplexing, isn't it? That you have got a clear-cut UIP pattern, but you are seeing this lymphoid infiltrate. So we need to figure that out. Anyway, summarizing the histological findings, we have a temporally heterogeneous process, predominantly established fibrosis and microscopic honeycombing, and active ongoing fibrosis, basically fibroblastic foci. What is crucial, what is very conspicuous is an inflammatory component with occasional lymphoid aggregates. Now, here I would like to point out something. When we are talking or dealing with neoplastic pathology in general, we make a bottom line diagnosis, for example, squamous cell carcinoma or adenocarcinoma or melanoma or whatever. In interstitial lung disease, it's important that we summarize our findings and we express features that we see which may not explain a classical example of something. So there is no, it shouldn't be taken as a compulsion that you are addressing it as UIP stop. It may not be just UIP. So it's always good to keep it open. You take the case back to the interstitial lung disease MDT, you figure out what's happening with serology, and then a final diagnosis can be made. So what I signed out this case was, excuse me, that the pattern is of usual interstitial pneumonia, but the inflammation is prominent. Could there be an underlying connective tissue disease? So with that, we go back to the ILD MDT. Reviewing the HRCT findings, the features were absolutely in favor of fibrotic NSIP. Histology was consistent with UIP, so I stuck to my ground that, okay, the pattern is UIP. So now, while all this was done, the connective tissue screen came back as negative. Now you have to put everything together. So if we tie up the clinical features, the HRCT and the histology, what is the consensus diagnosis? This is basically UIP, IPF. The reason it's important is, once we have made the diagnosis, the patient is entitled and eligible for the antifibrotic drugs. So this case illustrates that if there wasn't a biopsy and we had stopped on fibrotic NSIP on the HRCT, this patient would not have received these particular drugs. So this case illustrates the immense use of VATS biopsy made in this particular case. So sometimes we'll come across cases like this in an ILD MDT where you may have to review your pathological findings in light of the clinical findings, go back, look at the slides again, and there is always a discussion. And at the cost of sounding a bit philosophical, we need to understand that we are treating the patient, we are not treating the slide. So everything is taken into account, and then the clinician makes the best call, what is the best for the patient, and then go for the treatment. Now, moving on to the second case, Mr. BT, who was 60-year-old, the request card said interstitial lung disease. Now, I'm sure in your practice you must have come across this frustration when you have such limited information on your request card and you are basically scratching on your head, what am I supposed to be, what is my guiding light here? When it comes to cancers, it may be a bit different, but with cases like this, but hey ho, that's real world, that's what was there. Now, fortunately, when we look at the H&E sections, so this is the low magnification, and even at this mag you can see there is a bit of subpleural fibrosis which is dissecting down into the main lung parenchyma. You can see a bit of honeycombing, quite a few alveolar macrophages present as well, but otherwise just look at this interstitium, reasonably normal. So I'm basically hinting you towards the diagnosis. So we've got very good fibrotic areas, but here we have reasonably normal. And then we have slight mucoid impaction, very occasional giant cells, but again this is crucial, it's within the lumen. And around it you can see quite fibrotic areas. And then you start to see the diagnostic features. So this is again subepithelial, spindle-shaped fibroblastic cells, bit of inflammation, and this is a beautiful one where the epithelium is basically covering this fibroblastic focus, and another very nice focus of fibroblastic focus and established fibrosis. Now there are certain secondary features as well. So for example, look at that vessel, quite a prominent degree of medial hypertrophy. So secondary pulmonary hypertension is quite common in long-standing UIP IPF patients. And this is another very nice picture to show you a fibroblastic focus. And another low power view, quite established fibrosis with some honeycombing and some mucoid impaction. And this is another area highlighting the medial hypertrophy of the blood vessels. Honeycombing present as well. So those were the two examples of usual interstitial pneumonia, pattern-wise. Now, at this stage, I'll sort of digress a bit in the sense, talk a bit about a condition known as acute exacerbation of IPF. Now, this usually occurs in UIP, but can also occur in other fibrosing interstitial pneumonia such as NSIP. Now, HRCT is very crucial here. It typically tends to show bilateral ground glass opacities, GGOs, or consolidation, and you see a very reticular pattern or a honeycombing pattern in the background. Now, histology shows a mixed pattern. You see UIP areas with diffuse alveolar damage. Now, by diffuse alveolar damage, I mean you see hyaline membrane formation, intra-alveolar granulation tissue plugs. I'll show you a nice example in a few minutes. Now, it's very important to exclude infection, left heart failure, or any other identifiable causes of lung injury. Now, practicing where I practice, this is one of the areas where there is a bit of contention. So by what I mean is, sometimes we come across cases who have been clinically labeled as asbestosis because they have been exposed to asbestos, and they have a downhill course, patients die, and they end up on the postmortem bench table. And these people typically show features of UIP, which has been completely run over by a diffuse alveolar damage. Now, let me show you an example. So this is from a few years ago. This was a 76-year-old male who had a history of breathlessness on exertion. He had a history of asbestos exposure, and clinically this was thought to be asbestosis. Now, what had happened was he had a rapid downhill course with very increasing shortness of breath, and he died. Now, just to give a bit of perspective, I won't want to go into the detail. We have what is known as the coroner's postmortem system, coronial system. So anybody who dies where the cause of death is not known undergoes a postmortem, or if there is any evidence of industrial lung disease, for example asbestosis, if there is a history of asbestos exposure, the coroner would ask for the pathologist to do a postmortem. Now, in this particular case, the lungs were very heavy, very firm, very beefy, red looking, and the pleural aspect was very cobblestoning in type. This was mainly towards the base, and this is a low power view. Now, if you remember from a few slides ago where I showed you a typical two examples of typical UIP where you had a very patchwork pattern, if we look at here, it's reasonably sort of almost uniform. It's pink all over. I mean, those are artifactual spaces. So it's almost all pink. And why is that? So we go on a high power, and what is very striking is, look at the intra-alveolar fibrin. Absolutely pink blobs of fibrin. And with that, you have this spindly fibroblasts, myofibroblasts, basically intra-alveolar granulation tissue with lots of fibrin. There's a lot of alveolar capillary congestion as well. And this is a beautiful slide to show you the hyaline membrane. Look at that, this pink hyaline membrane depositing all along this air space. And you have a bit of inflammation around. And that's the diagnostic sign where you see a thin layer of epithelium, and underlying this epithelium you see this exuberant fibroblastic focus taking almost the entire area, and you have good going inflammation in the background, a lot of pinkness. Again, this is established fibrosis. Now, one word of caution here: the pneumocytes in patients with Uip IPF with diffuse alveolar damage can show such significant atypia that you can almost confuse them for malignant cells. If we look at these cells in isolation, we would definitely be worried that these are malignant cells, but clearly it has to be put into context. This is type 2 pneumocyte hyperplasia, bronchial alveolar metaplasia, which showing such drastic change. And you can see within those, along with those cells, you have this very pink fibrin present, lot of alveolar capillary congestion. And this is another area just to show you on a low power how metaplastic change can look so worrisome in a case like this. So that was what is known as acute exacerbation of idiopathic pulmonary fibrosis. Now, contrast to that, we come to another case. This is again from a few years ago, 82-year-old male who had a history of sustained and heavy occupational exposure to asbestos. He had worked in the Southampton docks in the 70s and 80s, and he had a pretty long history of breathlessness, and the clinical and imaging was just with asbestosis. You can imagine somebody coming with that background. It's reasonably confident diagnosis of asbestosis. Now, as I said in the previous case, this is industrial lung disease. All these patients, all these diseases have to have a coroner's postmortem. So at autopsy, what did I see? Extensive bilateral pleural plaques, which basically mean that the patient has been exposed to asbestos, and the lungs looked very fibrotic. And this is how the lungs look. Now, compared to the previous case, you can see here, it's very pink, but pink because the whole lung parenchyma has completely been distorted. You don't have any honeycombing, you don't have any other change, it's just pink fibrotic lungs. This is on a slightly high power. You can see these swathes of fibrous tissue replacing the entire lung parenchyma. And this is the crucial thing we are looking for as autopsy pathologists, asbestos bodies. So what you see are these very fine and slender. When you change your fine focus of your microscope, you can almost see the center of this, so which is like a thin needle-like structure on which you see this sort of brownish pigment. So basically these are ferruginous bodies. The reason they look like this is the asbestos bodies have been wrapped around by hemosiderin pigment. It makes it easier for us to locate that. And once you see that in a fibrotic lung, you can label a case as asbestosis. The criteria are that you should have sustained heavy exposure and at least 2 asbestos bodies in a 1 centimeter cube of lung tissue. This is another asbestos body from the same patient, slightly out of focus because I tried to click it on a very high power, and you see this bead-shaped structure with the fiber in between. And if one is lucky enough, one can almost find a culture of these, in the sense, in this one field there are so many asbestos bodies. So in a case like this, the autopsy diagnosis was diffuse pulmonary fibrosis consistent with asbestosis. Now, I won't go into the detail. In the United Kingdom, if a deceased has died as a result of industrial lung disease such as asbestosis or malignant mesothelioma, the next of kin or the family are entitled to compensation by the state government, by the central government. I'll take a pause here. If there are any questions, I'll be happy to take them, please. Thank you.
Yeah, thank you, Sanjay. Those were beautiful slides.
Thank you.
Yeah. So in the questions, we have one active participant, Dr. Jigme Wanchuk. He has just comment. Yeah, these are just words that he's typed. He's referred to some Mason bodies.
Yes.
Did you show any Mason bodies in your slides? Yeah?
Yes, exactly.
I
So
want
yeah.
to highlight that. Mm.
Okay, so Mason's bodies are basically yeah, I'll go back to the yeah. So that's a nice question. So basically, Mason's bodies mean intraalveolar granulation tissue plugs. So
Yes.
these are basically Mason's bodies. That's a name that's absolutely rightly used for that. Yeah. The Germans probably called it Bonjour conjunctives or something along those lines, but I can't quite spell it now.
Yeah, rose by any other name smells as sweet. So, as will Mason's body by any other name, it just does as much damage.
Yes. Yeah.
Yeah. So he also has the comment about cryptogenic organizing pneumonia. So
Yeah.
probably he's referring to an acute exacerbation.
Yeah. So acute exacerbation is usually in context of IPF and NSIP. Cryptogenic organizing pneumonia is completely another entity, and I will talk about COP maybe about 15-20 minutes from now or so. Mm-hmm. But I'll definitely be discussing COP as well, yeah.
So can Dr. Wangchuk clarify why he brought it up here? Did he have something in mind?
Yeah, Dr. Wangchuk is in YouTube. I've been copying his comments. Basically, just to put it in perspective, Dr. Wangchuk is being diagnosing as you're presenting. He's diagnosing it live. He's just giving diagnosis one after the other.
Okay.
Like if you see, first he called it UIP, the case which you presented as UIP.
Yes.
And as you were presenting, Dr. Jogai, he was trying to diagnose them. Like he had called some areas as Mason's bodies. Then he called it one of the cases as cryptogenic organizing pneumonia. The next he said mixed with DAD features. So
yeah, absolutely.
Right.
Yeah. So because he's on YouTube and it's not live, because YouTube is about a minute or so behind in the entire transmission of things. So as his comments are coming, I'm just pasting it on the chat box so that Dr. Sridevi can see them and he can present it to you. So he's also made a comment right away. He said, "Great presentation." So he's there. So we can take it up from there. We can just continue. Yeah.
And thank you for your active participation, Wangchuk.
Yeah, I just want to tell Dr. Jogai that there is that hide button there. Just if you press that pop-up will just go away. In the center of the screen, that hide thing, which if you see.
Shall I just click hide?
Just click hide.
Yeah.
That's gone. Yeah.
Okay. Thank you.
Great. So we can continue from there.
Right. Okay. Yeah. I think there are no other questions. You can proceed, Sanjay.
Okay. Thank you very much. Okay, I'll carry on. Yeah. So after UIP, we come to NSIP. So initially described in 1994, basically to encompass those interstitial inflammatory and fibrosing lesions that did not fulfill the diagnostic criteria for UIP, DIP, RB, ILD or AIP. So as the name sounds, non-specific. So it was a very descriptive term, and interestingly, it's the most common interstitial pneumonia that's associated with collagen vascular disease. Now, compared to UIP, the prognosis is considerably better. As I said in my earlier slides, in the ILD MDT setting, that's very important. So if a patient is NSIP pattern, that patient responds better to steroids, whereas if it's UIP pattern, they will go for antifibrotics. Now within NSIP, we have cellular and fibrotic form. Cellular form is better than fibrotic, and most patients respond to corticosteroids. So what's the cellular form of NSIP as far as pathology is concerned? It's a very diffuse involvement of the affected parenchyma. The inflammation is moderate, chronic, interstitial mainly. In the cellular pattern, you don't see much fibrosis. The alveolar architecture is preserved. Now this is very important when we compare to UIP, where the alveolar architecture is damaged. We don't see that in NSIP. It usually lacks either being centriocin or subpleural or paraseptal, by which I mean when you see subpleural or paraseptal, you are thinking about UIP. That doesn't happen. So basically, when we talked about UIP, we were using the term temporally heterogeneous. Here, it is temporally homogeneous. So it's the same thing across the slide. But when it comes to fibrotic involvement, the pattern still remains diffuse. The inflammation gets a bit, it decreases a bit, and you start seeing variable degree of interstitial fibrosis. And as I said, it's very homogeneous. The architecture is not lost. Now, with that, I'll share a few cases. So 61-year-old Mr. RWL he had a history of dry cough, shortness of breath for 4 months. Chest X-ray showed was persistently abnormal despite having 2 courses of antibiotics, and CT scan showed subpleural fibrosis, traction bronchiectasis with early honeycombing, which was worse at bases, and a peribronchial ground glass change. He was the chief executive of a charity, went on a skiing holiday, felt well and forgot about it. However, when he came back to UK, the cough returned and he was breathless on exertion. The clinicians thought we need to look for a biopsy, and interestingly, we were very lucky to have 2 VATS biopsies from the left upper and lower lobe. And this case will illustrate how different lobes can show different pathologies. So this is a low power view of the left upper lobe. Again, you can see a slightly more normal looking lung parenchyma, quite busy looking here. And when we go on a high power, this is what is very striking. You look at this intra-alveolar granulation tissue buds. Now, I hope Dr. Wang Chuk is very happy with this, because this is where I would definitely use the word Mason's bodies. So this is very much intra-alveolar rather than true fibroblastic foci. And this is important to understand because it's completely intraluminal. It's not the way we see fibroblastic foci just under the epithelium. So almost the entire area here blocked by this intraluminal proliferation of Mason's bodies. This is a high power view. Again, very beautiful example. You can see these spindle-shaped fibroblasts, myofibroblasts within intraalveolar spaces, a bit of inflammation around as well, and another area to show you chronic inflammatory cells, including lymphocytes, plasma cells, and few foamy macrophages as well. Now, compared to the left upper lobe, this is a section from the lower lobe. Again, a low power where you can't make out much except that it's very busy looking. Now, when you go on a high power on this wedge, you see a very conspicuous inflammatory component. There are those Mason's bodies or intraannulation granulation tissue plugs, but the inflammation is clearly overtaken the organizing process. Again, another area, a bit of organization there, but lot of inflammation, slight amount of mucus plugging. So summary of histopathological findings: within the upper lobe we had an organizing pneumonia with a mild chronic inflammatory cell infiltrate, whereas in the lower lobe we had a very cellular and significant inflammation with occasional lymphoid aggregates as well. Now, when I devise my pathology reports, it's important to include some of the negative findings as well. So I tend to use phrases, for example, when we do other reports, we are dealing with oral biopsies, we say there is no evidence of dysplasia or malignancy, and so on and so forth. In my ILD reports, I would use phrases like no true fibroblastic foci are seen, or there are no granulomas, or there is no vasculitis. It's important that you are showing to the clinician you have considered certain other entities as well, but they are not there. And it's a more comprehensive report. So the way I concluded was, overall features are a combination of organizing pneumonia and of NSIP, because we clearly have a very significant inflammation. And in view of the presence of lymphoid follicles, is there an element of connective tissue disease? And you leave it in the clinician's code, and that's where you stop. So we go over. Now, while this has happened, the patient has ended up having positive polymyositis scleroderma 75 and scleroderma 100 antibodies, and a weakly positive RNP ribonuclease protein as well. Plus, it has come to light that he has features of Raynaud's syndrome, which are worse in the last few months. No other inflammatory arthritis, no Zika symptoms, no rashes, no eye inflammation, no family history of autoimmune disease, and importantly, no exposure to birds. Now, I put this in red because I wanted to highlight so that I don't forget. This is one of the one of the issues that is there in pathology or diagnostics in general. While a patient has been worked up, so for example, a patient has already had a biopsy, the clinical workup is still not finished. So in this case, the pathologist has signed out a report even before all these tests were available. So the patient has come to the clinic, has been sent for various blood tests, has a biopsy, pathologist has returned the biopsy within 7 days, and then comes to know about all these things. So that's a constant problem, that not every patient will come to the pathologist desk fully worked up. But it's important what role pathologists can play in cases like this. So we took him to the ILD, MDT, and clearly the serology was so important here, taking together what we saw on the biopsy, which was both organizing pneumonia as well as an SIP pattern, and on serology this patient had a polymyositis scleroderma overlap. We could label this as connective tissue disease, interstitial lung disease. So this is an entity in itself. I'll be talking more about it in a few minutes. Now, follow-up, the patient was started on mycophenolate mofetil and prednisolone. There was an improvement in his respiratory symptoms as well as lung functions. Unfortunately, his Raynaud's is becoming more difficult to control. Case number 6, 49-year-old male presented with dyspnea on exertion. He was unable to work, could walk half a mile on flat, and had difficulty taking stairs. He was an ex-smoker, occasionally having smoked marijuana, builder by trade. There was a doubt whether he was exposed to asbestos, but it wasn't clear. There was no exposure to tuberculosis, birds, or animals. He had a history of chronic pancreatitis secondary to alcohol access. He was on metformin for diabetes and had a history of recurrent chest infections. Now, the CT scan showed a lower zone predominant traction bronchiolectasis. There was ground glass change, interlobular septal thickening extending to upper zones, but no honeycombing. So essentially all features which were favoring NSIP. The patient undergoes a VATS biopsy. And this is a low power view. So what I've done is I've sliced the lung wedge into multiple thin slices and put it in one cassette. And this is a low power view. So if we look at this side, more or less sort of normal looking lung, a bit busier here, maybe subpleural, something is going on. So let's explore what's going on. So on a high power, what's very conspicuous is the interstitium is clearly widened and you have got a good going inflammatory infiltrate, mainly lymphocytes and plasma cells. This is another focus to show interstitial inflammation. And you've got lymphoid aggregates again. As history was there of smoking, you can see lots of smokers' macrophages. These are pigment-laden macrophages. And this is something crucial which I would like to highlight. This is a section, this is a focus from the pleura. And you can see a conspicuous degree of inflammation within the pleura. And this is a high power, lots of plasma cells and lymphocytes, and a sclerotic collagenized type of background. We don't see this very often, so is this important? We'll come to in a minute. So summarizing the pathological findings, diffuse interstitial thickening by chronic inflammatory infiltrate, occasional lymphoid aggregates with follicle formation, pleural inflammation, pleuritis I mean, no fibroblastic foci, no granulomas. So as a histopathologist, I said, oh, is this NSIP pattern with some features suggestive of underlying connective tissue disorder? In this particular case, basically the pleural inflammation and the lymphoid follicles. Interestingly, like the previous case, he is being worked up while the biopsy is done. And there's a host of antibodies that they tested, all of which are negative. I won't read out each of them. But what was very important was, within the myositis ENA panel, they found this particular antibody, PL7+, PL7. Now, on further clinical examination, he showed Gottron's papules and mechanics hands. So, pathology pattern wise, this was NSIP suggesting CTD. Now, taking into account the antibody profile, this is a specific diagnosis. I must confess, till that time I wasn't aware of this particular condition. So this is what is known as an antisynthetase syndrome. So what is it basically? So the hallmark of antisynthetase syndrome is the presence of myocyte-specific antisynthetase antibodies. Now, usually they have this anti-Jo1, but less commonly they have these four. And in our case, this was basically anti-PL7. Now, a few words about ILD in antisynthetase syndrome. ILD frequently predominates at presentation and contributes to the high morbidity and mortality. In a particular study in 2013 of 203 patients, the prevalence of ILD was 86%. It was rather more common than the prevalence of myositis or arthralgia. HRCT is typical traction bronchiectasis, ground glass opacities and reticulations, and NSIP or organizing pneumonia or a combination of the two are the most common patterns. Patients are treated by a variety of treatment modalities. Our patient received prednisolone and rituximab, which, as you know, is an anti-CD20 antibody, and on follow-up, his breathing had improved and energy levels were much better. So, CTD ILD, this is a very important aspect of interstitial lung disease, increasingly so because of the advent of numerous antibody tests that are now available in the diagnostic armamentarium. So, the reason it's important to distinguish the two compared to an idiopathic pulmonary fibrosis is that CTD, ILD, IP is more favorable prognostic-wise compared to the idiopathic ones. Approximately 15% of patients who are so-called or apparently idiopathic are actually found to have an underlying CTD. And it's important, previously, like till 10-15 years ago, most physicians would just do AN and rheumatoid factor. But now we have a gamut of antibodies, and these are so important to pinpoint the diagnosis. In a very interesting paper by Homa and colleagues, they looked at 68 patients with idiopathic interstitial pneumonia and followed them up for more than 11 years. And of those 68 patients, actually 13 patients eventually developed connective tissue disease. So this again emphasizes the multidisciplinary collaboration, which is very important in terms of in interstitial lung disease. As a pathologist, we can't act in isolation. We can only give patterns. It is the clinical, the serological, the HRCT, and everything taken together. Now, when it comes to histopathological consideration, when should you be worried? When you see lymphoid aggregates with germinal centers, when you see a lot of pleuritis, or if there is a prominent plasmacytic infiltrate, or there is a dense perivascular collagen. So I wrote this last night that if as a trainee, as a pathologist, you are seeing features like this on a surgical lung biopsy done for a patient with suspected ILD, as a pathologist, we can play a very important role. We can suggest to the clinician, hang on, have you excluded underlying connective tissue disease? And it is so gratifying where you can play such an important role where based on your report, the physician has gone ahead and looked for all the antibodies and has come to a conclusive diagnosis. So again, I'm nearly halfway through. So I'll take 30 seconds. If there are no questions, Dr. Sridevi, Dr. Nadeem, I'll carry on, but please guide me.
Yeah, Sanjay, there are lots of questions and comments. So I think our audience is warming up now. Okay, we have Dr. Hemachandran, who has said that sometimes they get TPLBs and it's very challenging to give a conclusion on those biopsies. So we saw in your slides that you have comparatively a very generous portion of tissue that is given to you for processing and diagnosing. Likewise, we have Dr. Rajiv Kaushal also asking you what is your experience on core biopsies for ILD.
Okay, first thank you very much, Dr. Sridevi. First of all, going back to Dr. Hemachandran, he's absolutely right. The cases I've shown the example so far are patients where clinically there was no option but to do a VATS biopsy to arrive at a diagnosis. So this is obviously a bias towards, because I'm trying to show the pathological processes on these biopsies. I will in a few minutes share a few cases, at least one I can remember, of a transbronchial biopsy as well. The next question was from Dr. Kaushal. I must confess that as far as diagnosing interstitial lung disease is concerned, I have never made the diagnosis on a core biopsy ever, because either first thing is, as a diagnostic procedure, we would not do a core biopsy if the question is that of an interstitial lung disease. They would either have a VATS biopsy, or at the very least, if the patient is unwell or there are other compromising factors, we will do a transbronchial lung biopsies. A lot of centers, I don't think in the UK, but especially in America, they are now coming up with cryobiopsies, which is a very useful tool. But I must admit, I have no experience with that. So as far as the diagnosis of interstitial lung disease is concerned, open biopsy or a VATS biopsy is the best way forward.
Right.
Thank you.
There's another question from Dr. Syed. He's asking you that in UIP, is it that there is striking subepithelial and paraseptal fibrosis as opposed to NSIP where it is intraluminal?
No. First part of the question is correct. Yeah, it is paraseptal subpleural. NSIP is not intraluminal. It is still septal, but it is more temporally homogeneous. Once we are talking anything intraluminal, we are talking in terms of organizing pneumonia.
Yeah.
So intraluminal component itself is not interstitial. So in NSIP, we would not get intraluminal. Intraluminal proliferation will basically mean a very nondescript organizing process. So you could see it in a variety of conditions. So for example, as Dr. Wangchuk pointed out, you could see it in cryptogenic organizing pneumonia. You could see it in bronchiolitis obliterans with organizing pneumonia. You could even see it in extrinsic allergic alveolitis as a component of organization. You could see it in diffuse alveolar damages. It is a mere manifestation of an intraluminal process, but NSIP as such, the inflammation is interstitial, but it is more uniform rather than as as has been pointed out, that not paraseptal or subpleural.
Right. Yeah. So thank you, Sanjay, and Dr. Syed also has said thank you to you.
Thank you very much, Dr. Syed.
Yeah. There's another question from Dr. Wangchuk. Does any inflammatory cell have specific features to diagnosis, like specific to a particular ILD, a type of inflammatory cell?
Not really, but what is said is, if you see a prominent plasma cell infiltrate, you should raise the suspicion of a collagen vascular disease. That is what I would say. We will come to discussion of RB-ILD and DIP, where macrophages make more of the infiltrate. But otherwise, it's mainly lymphocytes and plasma cells. And if you see more plasma cells, you can raise the possibility of collagen vascular disease.
Right. Yeah. Okay. Thank you, Sanjay.
Thank you very much.
I think we have no more questions for now. You can proceed with the talk.
Okay. Thank you, Dr. Sridevi. I'll carry on. So, after covering UIP and NSIP, we come to the third common entity, which is EAA, or extrinsic allergic alveolitis. Now, just a bit of background. Acute cases, as you know, are rarely biopsied because the clinical is so striking. Within the first few months of the disease evolving, you see poorly formed non-necrotizing granulomas. There is widespread thickening of the alveolar walls by a diffuse lymphocytic infiltrate. You can see isolated giant cells with cytoplasmic clefts. Hilar nodes are unaffected. So the reason I put that here is because EAA shows granulomas, sarcoid shows granulomas as well. That can be a very useful imaging clue given to you, and I'll come to that point because Dr. Hemchandran has raised a valid point that if you have a transbronchial lung biopsy, how do you do? So we'll come to that with an example in a few minutes. You can see knots of granulation tissue within alveoli and respiratory bronchioles, which basically means evidence of organization. So going back to Dr. Syed's question, that you can see organization or intraluminal in a variety of conditions. So there is a diffuse background interstitial inflammation, unlike sarcoidosis. Sarcoidosis is very paucicellular. In late stages, granulomas tend to resolve. Inflammation is still peribronchiolar. In advanced cases, inflammation may progress to irreversible scarring. And that is the crucial bit, because at that stage, on histology, a patient, a case could look like UIP or NSIP. And it's very crucial here to pay attention to one important fact. I think this is the only aspect which I have underlined. The fibrosis in chronic HP is bronchocentric. Compared to NSIP, where you will see fibrosis would be more temporally homogeneous. In UIP, you will have extensive fibrosis, but somewhere you will see some bit of normal looking lung or fibroblastic foci. The fibrosis in chronic HP late stage is bronchocentric, and that's very important. Now, with that, we'll look at a few examples. Mr. DC was a 50-year-old male who presented with non-productive cough, weight loss. He had decreased exercise tolerance and showed diffuse alveolar shadowing on CT scan, and we had a VATS biopsy. Now, this is a very low mag. You can see a very nice cut section of a bronchiole with quite a busy looking peribronchial area. But what's important is, even within this surrounding lung, the interstitium is slightly widened. It's a bit low power. Now, if we go on high power, just to go back to the interstitium, look at that. This is not normal interstitium. We should not be seeing so many inflammatory cells within the interstitium. And this is a bronchus, a bronchiole, and you can see a very conspicuous peribronchiolar inflammatory infiltrate. Now, going to the next slide, that's a bronchiole, and look at that inflammatory infiltrate. I think we can appreciate there are some cells which are showing cytoplasmic granules. So these are eosinophils, quite a few histiocytes, but otherwise lymphocytes and plasma cells. And that's what we are looking for. Now, a scanner, we can easily miss this. And in the next few slides, I would like to emphasize on the importance of the type of granulomas that you see in EAA, and then contrast that with sarcoidosis, because that's a very important message we need to take here. Look at this area. So you basically have a cluster of maybe 6 or 7 histiocytes which are just together, surrounded by some plasma cells, occasional eosinophils. So it's like a very poorly formed granuloma. It's not compact or tight. And look at this area. Again, there are scattered loosely present epithelioid histiocytes with very prominent inflammatory infiltrate. And this probably is one of my favorite slides. Look at these slipper-shaped cells, so-called sort of epithelioid histiocytes. But again, what's important, very intimately admixed with inflammatory cells. So the granulomas are not well formed. Now, till that time, till I had that, the previous slide, I had no idea what was going on this patient's background history, because I wasn't given any history. After the ILD MDT, we discussed, we said, oh, this on H&E looks like EAA. Does the patient have any history? The nurse specialist went back to the patient and found, because they did not consider it maybe initially, that the patient had this particular type of bird. So I had to Google this image. Basically, this is, we call it budgies or budgerigers, and that's what the patient had at his house. So we, taken with that history, with the histological findings, we have a very definitive diagnosis of extrinsic allergic alveolitis or hypersensitivity pneumonitis. Now, there is another example. So 63-year-old lady, that's all the request card said. Query EAA, transbronchial biopsies. Now, I don't know the background of why they did a transbronchial biopsy, but this is probably my only case where I can illustrate this. So, you would know from your practice, transbronchial biopsies can be very frustrating. You may see very scanty tissue. It may be non-diagnostic. You may say a few inflammatory cells, and it's very frustrating because you are not satisfied, because you can't offer a definitive diagnosis. But lo and behold, if you have a case like this, look at this. This is a transbronchial lung biopsy, and it's a very low mag. And even at this magnification, you can see something wrong is going on there. There are those giant cells, and there's a bit of inflammatory infiltrate. And we look on a high power, and that's beautiful. You have these foreign body and probably Langerhans type of giant cells, lymphocytes, plasma cells, occasional eosinophils, and look at this giant cell. There is a cholesterol-like cleft or a refractile cleft inside these. So a transbronchial biopsy in this setting where the clinical question is query EAA, it almost clinches the diagnosis, isn't it? Because these are not well-formed granulomas. They are not paucicellular granulomas. They have quite a good going lymphocytic cuff around them. They're showing eosinophils. They are showing these clefts-like spaces. So if you put everything together, and additionally, in some areas, you can see these are intraluminal. So going back to the previous question in the discussion, we can see evidence of organization or intraluminal granulation tissue plugging in a variety of interstitial lung diseases. So this is a typical example of extrinsic allergic alveolitis, which is also showing evidence of organization. You can see this area, lots of giant cells and some clefts. So this, taking together the histological features and the clinical features, this is a case of another case of extrinsic allergic alveolitis. So in this particular case, the transbronchial lung biopsy has been very useful. Now, while I was preparing this talk, I thought it would be a good idea to contrast this with something which is again a non-necrotizing granulomatous process, and this is from the files from a recent case, a 41-year-old who presented with exertional dyspnea and non-productive cough. He had fever and night sweats, chest x-ray, bilateral nodular shadows. So anyone with any interest here would straight away think, why are we having bilateral nodular shadows? That's pointing us towards one diagnosis, isn't it? Interestingly, no birds, no pets at home, no arthralgia, skin rash, or any other connective tissue disease. And this is a low mag. So very nice wedge, and you can see reasonably normal appearing lung parenchyma with these pink areas on a scanner. You go on a high power, and it's a very beautiful example. So you look at these very compact paucicellular granulomas. There is hardly any inflammation here. And we go on a high power. Look at this compact nature of the granulomas. They are non-necrotizing. There's barely any inflammatory infiltrate. I tried my best, but I couldn't find anywhere where I could click a picture for Schaumann or steroid bodies. Having said that, they are not specific for the diagnosis, but it's good to see them. They look beautiful under the microscope. And this is another focus. What I want to emphasize here is, if you look at it in isolation, it's compact, but centrally, you have a bit of as if early necrosis. Now, a word of suggestion here, you may sometimes see tiny bit of necrosis in sarcoidosis. Please do not think just finding that will merit a diagnosis of tuberculosis. It is a good idea to do the stains, do the routine bug stains you would in practice, but the pattern, the distribution of granulomas, which is along lymphatics, subpleural areas, non-necrotizing, compact, is so typical. Now, in this particular case, we even had bilateral hilar shadowing, so we have no doubt. And this is an area which is showing dense sclerosis, very, very hyalinized, and you can see very few granulomas. Now, when I was taking pictures, the reason I included this picture was for something specific. What it is sometimes you will get mediastinal masses that have been core biopsied, and you'll see a very sclerotic looking sclerotic looking tissue, and you are wondering what the diagnosis is. You have looked for Hodgkin and Reed-Sternberg cells, you excluded no epithelial cells, no malignancy, nothing. But this keloidal type collagen, I found a very useful feature. If you cut levels, if you can even see some suggestion of half a granuloma or something, you can definitely raise the possibility of sarcoidosis. Obviously, there's no need to make a definitive diagnosis because you don't want to be wrong there. So the whole point is sarcoidosis often shows this very hyalinized, collagenized stroma, and that's a good clue to the diagnosis. And as I have already alluded to, the granulomas are rather compact, very paucicellular. Also, the Robbins, I think, uses the inelegant term of naked granulomas, so-called naked granulomas. So this one with the clinical, I haven't gone into the details because you know a lot about sarcoidosis, so I'll stop there. So this is a typical example of sarcoidosis. If you have doubt, it's a good idea to sign out as non-necrotizing granulomatous inflammation, suggestive of sarcoidosis or consistent with sarcoidosis. If you don't have any clinical features, if you have typical reticulonodular shadowing on imaging or higher lymphadenopathy, you can be reasonably sure that this is sarcoid, and then the patient is treated accordingly. I think it has been a very brief stop, so I think I'll carry on and maybe take questions a bit later. That brings us. Sorry.
Sanjay, if I may interrupt you, I think there are a couple of questions which may be relevant to this part.
Please, so yes, please.
If it's all right with you, we can take this.
Yeah. Absolutely.
Yeah. So, Dr. Rajiv Kaushal has come back to this topic of core biopsies again, because I think that is the main bulk of the tissue that people get in India. And he's raised a problem where sometimes you end up getting tissue from the periphery of a mass that might be a case of tumor arising in the background of ILD. And there is a concern whether to raise the possibility of ILD at all on core biopsies.
Okay, valid point. Again, I would reiterate, and I must admit, I have no experience of receiving core biopsies in patients with a suspected diagnosis of ILD. Having said that, I'll describe a bit more in this. So sometimes when we get cases for example, we have lobectomies or segmentectomies or wedge resections for lung tumors, as going by the college data set, we always take sections from the background lung, whether there is any abnormality. Yeah. Now, if people are smokers, we see RBILD or DIP pattern in the background. Once in a while, in the background lungs, we will see changes which are very suspicious of UIP. So for example, we are seeing fibroblastic foci, we are seeing a subpleural distribution, and we are seeing honeycombing. What we tend to do then is we go back to the macroscopic specimen, take additional blocks, and if those findings are reflected in the rest of the sections as well, we immediately alert the clinician, hang on, you have taken the lobe out for adenocarcinoma or squamous cell carcinoma or any other type of non-small cell carcinoma, but within the background lung, we are seeing changes of UIP. And please, could this patient be discussed in the ILD and taken it from there? As we can imagine, the main worry there for them is, for the clinician and the oncologist, is treating the cancer. But as a pathologist, you are fulfilling your role that you have raised the possibility that the background lung is showing ILD. Because it is well known that people with pre-existing ILD can develop cancers as well, and they behave in a very worse. You can imagine that if one of the lobes is out and the background lung is showing UIP, it will clearly have a very significantly worse prognosis. But going back to Dr. Kaushal, core biopsies with a question of ILD, I don't know how one would deal. I think I would err on the side of caution. If you're seeing a clear-cut indication of malignancy, you would say, in my opinion, that so-and-so malignant tumor or malignancy is seen. However, the background lung shows fibrotic change. And please discuss with the specialist radiologist or chest physician to exclude an underlying interstitial lung disease. I would be a bit conservative, because you don't want to give a diagnosis in isolation in a core biopsy. The other reason is tumor elicits a very prominent desmoplastic stromal response. So I would be a bit conservative and err on the side of caution with regards to ILD diagnosis on a core biopsy.
Right, yeah, that's very wise advice. We have a query from Dr. Shravani Chakraborty. If there is no bronchiole and no granuloma, but the clinician is insistent on getting a diagnosis of a granuloma because of his clinical findings, how do you proceed? Do you support it or stand by your histology findings?
Oh no, I completely agree with Dr. Shravani. I think as pathologists, we have to stand our ground as well in situations like that. Why should we be forced by the clinicians to make a definitive diagnosis in the absence of scanty representative material? I think I would strongly advise that she should report what she is seeing, and I completely agree with her. I mean, the most you would do in cases like that is cutting levels. I had one of my seniors when I took up the job many years ago, who said, if you have got, for example, transbronchial lung biopsies, and the clinician is questioning sarcoid or EAA, yeah, and you are sure that you are not seeing any cancer there, what is the use of this block remaining in archive? Cut the block through, go through 15 levels, 20 levels, 25 levels, exhaust the block. If while doing so you find one granuloma, half a granuloma, you can suggest, because there is no point in that block sitting in your filing cabinet, because you could have offered the diagnosis. So that would be my only advice. If you have a if you have a transbronchial lung biopsy or any type of biopsy, just exhaust the tissue with gentle levels. You may be lucky to find a granuloma, and that would be so satisfying.
Right, but we always have to wonder about cutting so many sections and staining so many sections and and the cost
Yes.
of
Yes.
yeah.
I agree with that.
Yeah, right. Okay, there are no more questions at this point, so I request you to proceed, Dr. Sanjay.
Okay, thank you, Dr. Sridevi. So we then come to COP, or cryptogenic organizing pneumonia. Now, as the name says, it's cryptogenic, so we don't know the cause. As far as pathology is concerned, what we see is organizing pneumonia. Now, it's usually a subacute illness of relatively short duration with variable degree of cough and dyspnea. HRCT is very striking. You see patchy and migratory consolidation in a subpleural or peribronchial or a band-like pattern. On histology, you see organizing pneumonia. Basically, it's within alveolar ducts and alveoli, with or without bronchial or intraluminal polyps, so-called Mason's bodies. Some cases may show marked interstitial inflammation, and then NSIP will enter the differential. Thankfully, most patients recover with oral corticosteroids. Relapse is known. In some patients, you can have fibrosis. But when you see that, you have to be careful about the clinical. Is there an underlying polymyositis or an antisynthetase syndrome-like condition? So I must admit, we don't see many cases with cryptogenic organizing pneumonia coming to biopsy. I must be honest there. So this is one from the file. This definitely is more than 5-6 years old. Mrs. ZZ, a 60-year-old lady with 6-year history of cough and recurrent chest infections, not settling with antibiotics. She was an ex-smoker, and they did a Watts biopsy of the right lower lobe. And this is how the lung looked like. So you can see a very nice patchwork pattern in this sense. This is almost normal. This is very purple, pink looking. Again, a bit of normalish areas in between. And when you go on a high power, this is very striking. It's a very cellular looking lung tissue. So you have this interconnected intraalveolar granulation tissue polyps, and quite a prominent inflammatory infiltrate. And look at this. So within alveolar, you have this proteinaceous fluid, a bit of fibrosis as well, and another area with quite conspicuous inflammation. But look at this intraalveolar. It's getting quite organized. But if we remember from UIP, these are not true fibroblastic foci. These are all very much intraluminal, interconnected. And this is a high power just to show you plasma cells, lymphocytes, scattered eosinophils as well. So as a pathologist, actually you wouldn't, I do say that diagnosis is COP, but as a pathologist, you are seeing organizing pneumonia. Once the clinicians have excluded everything else of the underlying cause, they would then call it cryptogenic organizing pneumonia. Now, we then move to other entities which are slightly brief. Desquamative interstitial pneumonia is, almost always you will see it in smokers, and CT scan you will see bilateral ground glass opacities with centrilobular nodules. So case number 11, Mr. RD, a 54-year-old male. So he was referred from another hospital. So we didn't have too many details. All I knew was he was a smoker, he had breathlessness, but I didn't know how long that was. He was obese as well, and we had the right lower lobe wedge. Now, compared to all the other cases we have seen, there is a bit of difference here. So, a lot of normal looking, but look at this on a high power. Within the alveolar spaces, you have got these very prominent pigment-laden macrophages, which entirely ties up with the history of smoking. And the interstitium is slightly widened. There is a bit of interstitial inflammatory infiltrate. And another area absolutely packed with alveolar macrophages. Occasional eosinophils as well, plasma cells, lymphocytes. And this is an area where there is some reactive type 2 pneumocyte hyperplasia, a bit of organization, and again alveolar macrophages. So going back to the first few slides, there is this entity RBILD-DIP. So it's like a spectrum which is seen in smokers. So in a proportion of cases, you can have a very prominent peribronchial inflammation where it is more like respiratory bronchiolitis pattern. Another spectrum, you could have a very much an intra-alveolar proliferation of macrophages where it is a DIP pattern. Now this particular case clearly shows lots of intra-alveolar macrophages. So we said it's overall favoring a desquamative interstitial pneumonitis. Case number 12, 45-year-old male smoker, presented with pneumothorax, and we got a left upper lobe wedge, and this is the wedge. So more or less normal looking lung, but we have this very ill-defined nodule, not exactly a stellate shaped scar or anything, but clearly something going on here. We focus this on a high power, and what do we see? What's most striking is that the eosinophils are very, very, like, they catch your eye straight away. But apart from eosinophils and these pigment-laden macrophages, you have a proliferation of cells which have sort of vesicular pale nuclei. I don't know if I can convince you. Some of them have grooves, and some are sort of folded or sort of reniform in shape. So sort of a histiocytic proliferation. Now, if you get a wedge in a young patient who is a smoker, has had a pneumothorax, on a scanner, the first thing to look for is, are there any stellate shaped area? Are there any nodules? Zoom in on those nodules. Look for the inflammatory cells. What is the inflammatory cell component? If you've got eosinophils, if you've got those mononuclear cells, always do immunohistochemistry. So this is S100, which beautifully highlights all those cells, plus picks the macrophages. This is CD1A, which is strikingly positive in a proportion of cells. And more recently, we have acquired Langerin as well, and most of the cells are Langerin positive as well. So this is an example of Langerin cell histiocytosis. At this point, I would quickly remind you, this Langerin cell histiocytosis is completely different in terms of behavior, prognosis, clonality, and everything compared to the LCHBC in children or in bone or in skin. This is a smoking-related condition. So almost exclusively in smokers. The interesting thing is sometimes you will come across patients who are not smoking anymore, but it's a good idea to ask them, have they smoked before? Are they ex-smokers? They typically present with cough and dyspnea with multiple pneumothoraces, and chest X-ray shows reticulonodular shadowing in the mid zones with sparing of CP angles. And in later stages, you can see cyst formations. In advanced disease, you have the enlarged cyst, which involve all zones. Typically peribronchial lesions. Because they are peribronchial, the weakened bronchioles lead to cyst formation, and healing is formed. Healing leads to stellate fibrous scars. So the clue is, if you see stellate shaped scar, always be worried. Differential diagnosis is from eosinophilic pneumonia, where you'll see lots of eosinophils, but a lot of it will be intraluminal, and reactive eosinophilic pleuritis. A histology tip would be, if you see aggregates of mononuclears of histiocytic cells with eosinophils in scar-shaped areas, always do immunohistochemistry. It's very useful. You can clinch the diagnosis with that. This is from a textbook from Corin and Nicholson, very advanced case. So you see a lot of cyst formation. And again, this is from a textbook as well, because I haven't seen a lobectomy or a lung taken out for LCH, and you can see such extensive cyst formation. Case number 13 was a 76-year-old lady. She had a lobectomy for an adenocarcinoma, and section is from the background lung. This is a bit of trivia because it just popped up a few weeks ago. So this is a section from the lung. I won't focus much. There's something going on here. And on a high power, you clearly have an adenocarcinoma. So at this stage, I would say that the carcinoma was there in many sections. But what was very interesting was in the background, just next to the carcinoma, you had a proliferation of pale, sort of pink, spindle-shaped cells. And on a higher power, you can see they're relatively bland, almost tapered end, lots of eosinophilic cytoplasm, no necrosis, no mitotic figures. And this is a high power. You can see this sort of blunt-ended nuclei. Now, if you see something like this, there's only one entity you have to think of. I'm sorry, I don't have the immunohistochemistry. I ran out of time to click pictures. But these cells were smooth muscle actin as well as desmin positive. And HMB45 was focally positive in a proportion of cells. So this is an example of lymphangial leiomyomatosis. It's quite striking that it's in a patient who's already got cancer. Usually you see it is as wedges. Now, just a quick few words about lymphangial leiomyomatosis. It may be sporadic or associated with tuberous sclerosis complex. It's virtually restricted to women of childbearing age. Patients present with dyspnea or pneumothoracis or chylous effusion. On HRCT, typically you see cysts throughout the lungs, and basically these are modified smooth muscle cells. Immunohistochemistry is absolutely crucial to make a diagnosis. So smooth muscle actin and desmin are strongly positive. HMB45 may be focal or faint. With the advance of finding out these mutations and everything, it's now believed to be neoplastic conditions. And in familial cases, you will find mutation in the tuberous sclerosis 1 or 2, and in sporadic cases in the TSC2. This is another case. This is a wedge. And a very busy looking, so I think I've skipped a slide here, sorry. Yes, sorry. So this is case number 14, Mrs. JB, 39-year-old female. All the request card stated was left lower lobe aspergilloma, left VATS apical segmentectomy, query infected. And this is how the wedge look like. Very busy, very, there's hardly anything normal there. And on a high power, you see lots of foamy macrophages, a bit of organization, mixed inflammatory infiltrate. I mean, quite impressive, but what is causing all this? We are not sure yet. And then, when you look around carefully, you come across these cells scattered throughout actually. Once you get your eye into those, you can see there are some intranuclear inclusions. And this is another very beautiful area where you can see this owl eye-like inclusions within the pneumocytes as well as the endothelial cells. And I was quite puzzled when I saw that history was very curious. They were querying an aspergilloma, and here we have got absolutely staggering example of Cmv Pneumonitis. So, sorry. So basically this was cytomegalovirus pneumonitis. We didn't see any aspergillus or any other organism. Now, as what happens in cases, you go back and you dig the full history, and then I came to know that the patient actually had refractory AML and she was post stem cell transplant. So clinical history was very important in that case, as in every other case actually. We then come to acute interstitial pneumonia. We don't see, I mean, at autopsy, you would hardly come across situation like this. In surgical pathology, you'll hardly come across situation like this. More or less, these are examples which would come either at autopsy or will be diagnosed clinically, and you don't see many. So basically, they present with rapidly progressive hypoxemia with a mortality of 50% or more. If you do get a biopsy, you'll basically see diffuse alveolar damage. In the organizing phase, hyaline membrane may be inconspicuous or absent. You may see loose organizing connective tissue, type 2 pneumocyte hyperplasia may be prominent. You may see background fibrosis. And if you see features of UIP, you should raise the possibility of acute exacerbation of IPF, which I alluded to earlier. Patients who may be clinically thought of as asbestosis, for example, they have a sudden downhill course. At autopsy, all you see is diffuse alveolar damage in a background of UIP, and that's what it is. Some people can progress to fibrotic NSIP pattern or show severe honeycombing as well. A quick few words about lymphoid interstitial pneumonia, may mimic infection. The important thing is a very dense cellular infiltrate. You see the septa are very much expanded. Now someone could ask, what is then the difference between lymphoid interstitial pneumonia and NSIP, for example? The difference is that you see a lot more lymphoid or lymphocytic infiltrate in LIP compared to NSIP. Now this is not one of my cases. This is from a book. You see a very widened interstitium with almost exclusively lymphocytic infiltrate. Now, this is a tricky situation as far as surgical pathology is concerned, because there are several entities which can come in the differential. What I find most useful is if you see a very heavy lymphoid infiltrate, including follicle formation and peribronchial, a good idea would be to do a panel of immunohistochemistry. So do the routine B and T cell markers. What I find very useful is light chain restriction. If you can demonstrate light chain restriction and the pattern is typical, you are basically dealing with a marginal zone lymphoma. Hopefully, I have a case in my files in the last week of reporting, and hopefully I'll be able to show it to you in one of the meetings in future. And if you're still in doubt and it is difficult whether you are able to say it is clonal or not, PCR would be useful. And again, it's going back to the clinical correlation. If on imaging, is it a mass forming lesion which you can clearly see, which would favor a marginal zone lymphoma or Malt lymphoma, or is it a more diffuse lymphoid infiltrate? So clinical is important here. So I finally come to the last few slides of this talk. It has been really interesting. When I was preparing the final few slides last night, I came with these sort of the last two slides, and I must say at the outset that this is not all inclusive. This is whatever came to my mind, and these are subtle clues or hints. It's not an all-inclusive list of everything, but I'll just enumerate. So first and single most important thing is pathologist cannot report in isolation when it comes to interstitial lung disease. It's the triple test in a way, so clinical, radiological, and pathological correlation. If it is possible, if one has the facility, an interstitial lung disease meeting is a very good forum to describe that. Now then coming to pattern recognition, a few words of suggestion or advice as you may wish to take it. First thing, is the pattern diffuse? So when you put on your H&E slide and you look it on a scanner, is it diffuse? And if it is diffuse, is it heterogeneous or homogeneous? If we go back to our first few slides, temporal heterogeneity would favor a UIP. If it's all the same and an inflammatory pattern, would favor NSIP. Is the inflammatory component diffuse? Again, it would favor NSIP. Is it bronchiolocentric? Can you see any granulomas? Then go for EAA-HP. Are there lymphoid aggregates or follicles? If you see those in a background of UIP pattern or NSIP pattern, always suggest to the clinician, please exclude connective tissue disease as the underlying etiology, because in that case, they can treat the connective tissue disease and the lung disease will improve. You are not making a diagnosis of idiopathic NSIP or IPF. You are basically giving them that it's possibly a connective tissue disease, ILD. Then, is there fibrosis? Is it uniform and septal, as was asked in one of the questions? So if it is uniform and septal, we are talking about NSIP. Is it subpleural or paraseptal? Then we are talking about UIP. Then are there true fibroblastic foci? Now, I must say and re-emphasize here, it's not always UIP if you see fibroblastic foci. You can see it in other conditions as well. Mere presence of fibroblastic foci does not make a diagnosis of UIP. It can be seen in other conditions, especially like NSIP. And the second is there evidence of any intraalveolar organization? Now, as was raised by a few other questions, that it's not a specific feature. You can see it in a variety of conditions. You can see it in EAA, you can see it in COP, you can see it in DAD. So it's a pathological feature of many entities. Next is, are there granulomas? The quality of granulomas, how they look. I mean, we are not talking about necrotizing granulomas here at all. So we are completely taking out infections like tuberculosis or fungi completely. If they're loosely formed and peribronchial, we are talking about EAA and HP. If they're compact, paucicellular, so-called naked granulomas, we are hinting towards sarcoidosis. This is one very useful take-home message. If you come across a wedge in pneumothoracis for young males, smoking, who are smokers, LCH should be your top differential. Always look carefully for any eosinophils, any mononucleocells. Do immunohistochemistry and you'll have a diagnosis. In young females, subpleural spindle cell proliferation, always think about LAM. Underlying CTD, obviously you have to advise serology. Without that, as a pathologist, you'll be offering morphologic diagnosis, not a complete clinical diagnosis till you have that serological correlate. Always important to remember, mixed patterns exist, so you can have something in one lobe, something else in the other lobe. Family history is important. I must say, as a pathologist, I don't come across many familial interstitial lung disease, and then exposure history. You may be making a diagnosis suggestive of HP or EAA. Is there an exposure to birds or animals or anything else? And that sort of thing. And any questions at this stage?
Okay, Sanjay, like our audience has been very active, very participatory, and most of the diagnoses are spot on. As soon as you're showing the slides, we have the diagnosis coming up. We had Dr. Wangchuk diagnosing the Langerhans histiocytosis and Dr. Syed diagnosing the Cmv Pneumonitis. Dr. Wangchuk wants to know that if you want to confirm a case of Langerhans histiocytosis, how many stains you need to do to confirm the diagnosis?
I think, like, till we had Langerhans, thank you for the question, Dr. Wangchuk. Till we had Langerhans, we were absolutely happy with S100 and CD1A. And till we didn't have CD1A, we were happy with S100, because the routine histiocytes would not show the morphology together with S100 is good. So if one can have S100 and CD1A, that is good. If one has the facility of Langerhans, even better. But I think it's a valid point. So it is going back to morphology. If you see stellate-shaped scars or nodules within a wedge where you have those pale staining cells with grooves or clefts with eosinophils, and if they're staining with S100, I think I would be happy. It's just that we have the luxury. If I didn't have, I would still want to make a diagnosis with S100 positivity.
Right. I just had an observation. You mentioned that LAM is almost always confined to young women of childbearing age. And it was interesting that your case was in an elderly woman with adenocarcinoma. She was, I think, 70 plus. So there are always exceptions to what.
Yes, absolutely. No, absolutely very valid point, Dr. Sridhavi. I was fascinated as well. What I haven't shown you in that case was, it was the most unusual case, because even within the hilar nodes that the surgeon had sampled for like lung staging, we do the complete like the systematic nodal dissection. Even within the nodes, she had LAM. So we didn't quite make out was because she didn't have, to the best of my knowledge, she didn't have tuberous sclerosis. She was 70 plus. So we raised the possibility, and I don't know whether it was just, it had been there and she was with it for all these years. But no, that's a valid point. Probably that's the only case I've seen at that age group. It's pretty uncommon. I think we see a case or two every year or every few years, whereas LCH we see more commonly.
Right. Yeah, this was a question which was very much on my mind too. Dr. Rajiv Kaushal has brought it up. Any experience of COVID in ILD patients? Or rather, I would also extend that question to what is your experience with COVID patients now? We are hearing a lot about patients on long-term follow-up who've been COVID positive. We're going to expect a lot of lung fibrosis.
Yes, yeah, very, very pertinent question. So the way I would share information on that is, When COVID started in the UK, the first several months, the Royal College of Pathologists came up with the dictum that once somebody is COVID positive, we do not need to do autopsies. And once the clinician is happy with the COVID-19 diagnosis, the death certificate would be signed. So our life was much easier. In the last 3-4 months, what has happened is the college has changed the stance. And now the coroner, who is basically the legal or the legal person, is asking us to do autopsies on COVID patients also. The reason why they are asking us to do autopsies is not all patients with COVID are dying of COVID. So they may have other comorbidities. Somebody may have fallen in their home, this, that, and lot. Cutting the long story short, in the last 5-6 weeks, I have done 6 autopsies on COVID patients. I have done 6 autopsies on COVID positive patients. The lungs are very, very dramatic in all those patients. They typically show findings which look like what I showed in acute exacerbation of Ipf. In the sense, each of the lung would weigh between 800 grams to 1000 grams, very heavy, very beefy red, and when you compress them, it doesn't ooze pus like it would ooze in bronchopneumonia or community-acquired pneumonia. And when you look under the microscope, there is diffuse hyaline membrane formation with intraalveolar granulation tissue polyps, so-called Mason's bodies, sparse inflammation, and you can make out that the lung is completely drowning in that. Now, these are patients who have had COVID for a few days to a few weeks and then have died. Now, the question is a very good one. What about long COVID? I haven't come across a case yet where the patient has died several months after COVID, except one where the patient developed secondary bacterial bronchopneumonia. So it would be very interesting, but it's a very valid point Dr. Kaushal makes, because the physicians here are already starting to bear the brunt of long COVID. It is both on their health as well as the workplace. So people are being signed out of work for prolonged times. They are still not able to come back to work because they continue to remain breathless, and the long COVID is genuinely a cause of concern. It would be interesting in months or years to come when we will be able to have, God forbid, an autopsy series of cases like this where patients have survived and gone on to develop pulmonary fibrosis. The initial data suggests that the fibrosis is very much a diffuse interstitial fibrosis, but more than that, I'm afraid I don't have much knowledge.
Yeah. Thank you for a very elaborate response. Dr. Hemchandran is also asking you if you have any experience with ILD in the immune compromised.
ILD in immunocompromised. Good question from Dr. Hemchandran. I must say no. The only example I can think of is that Cmv Pneumonitis, where the biopsy was done as query aspergilloma, and I wasn't told that there is any background immunocompromised. I can't think of offhand from the top of my head ILD coming in immunocompromised. It probably would be some kind of inflammatory pathology. I would think whether it would be mass-forming lesions like CMV or pneumocystis or other fungal infections, aspergillus, angioinvasive aspergillosis. I can't think of a proper ILD in an immunocompromised setting. No, pass is my answer. I must confess, I don't know.
Okay. So you have a lot of congratulatory notes coming in. Both Dr. Syed and Dr. Wangchuk both have thanked you for a wonderful talk and an amazing presentation. Incidentally, Dr. Pgimer Wangchuk is from Thailand. So we have somebody joining us from Thailand. That's really nice.
That's very kind. Thank you very much.
Yeah. There's one from the audience just calling himself or herself NP. Any experience with lung interstitial disease and use of biologics in medical practice? A comment, transbronchial lung biopsy is not necessarily to make a diagnosis, but a negative biopsy is equally helpful for management. So there are basically 2 comments here, one question and a comment. Any experience with interstitial disease and use of biologics?
No, negative to the first question. So no, I have no experience, so I'll be honest there. With the second question, I will take that with a pinch of salt, because a negative biopsy, one has to also consider the representation. So for example, we do a transbronchial lung biopsy in somebody who is suspected to have EAA or sarcoid, but has a negative biopsy. Does it exclude? I would have serious reservation about that. A positive diagnosis would definitely help us, but that's my opinion. A negative biopsy, how do we exclude if clinical is favoring an EAA and sarcoid? I think the clinicians would still go ahead and treat if they are sure about it, even if it's a negative biopsy.
All right. And what about IgG4 mimicking ILD?
Yes, very nice question. Yes, IgG4, most of the time when we are seeing it in lung, it's either presenting as a mass lesion or it is present very uncommonly in core biopsies. I must admit I've seen only 2 or 3 examples where a mass lesion was biopsied and there were lots of plasma cells with storiform fibrosis and obliterative phlebitis, and we did IgG4 stains, and that made the diagnosis. Usually IgG4 will present as mass lesion rather than an ILD pattern. So in my experience, I wouldn't be able to say whether ILD presentation of IgG4, again a pass, no. My experience is more with mass forming lesions. So something that has been biopsied as a tumor, and we have raised the possibility of IgG4 that I've seen. And hopefully in future I might be able to show an example.
Right. So Dr. Hemachandran is saying that thank you Sanjay, very good collection of cases and a very good talk. So
it's very kind of Dr. Hemachandran. I entirely reciprocate, and thank you very much for listening.
Yeah, and so is Dr. Shrabini Chakrabarti. Very good presentation. Thanks a lot.
Thank you very much, Dr. Chakrabarti. I appreciate that.
Right. So we've been online for close to 2 hours and we never noticed the time pass because you were so, you had us in the grip of ILD for 2 hours.
No, that's very kind. It was a pleasure. I mean, I was a bit hesitant because with all the technical things and all, but no, it has been my absolute pleasure and privilege to be able to do anything.
Yeah, I think you're very passionate about your subject. And it's also very nice to see how thorough a workup you get to do with your patients. So I'm sure it gives you a lot of satisfaction to reach a good conclusion, a well-rounded, well-informed conclusion on most of your patients. So that's really nice to see. Yeah.
Thank you.
And you've also been a very good teacher, I think, to all our audience today. Very clear explanations, very practical approach, backed up by beautifully stained and cut slides. So thank you very much.
Thank you very much.
We have a last note of thanks from NP. Thank you. Excellent case-based presentation. So
thank you.
If there are no more questions, I'll hand over the platform to Dr. Nadeem. And thank you, Sanjay. It was a pleasure to moderate this session with you, and I learned a lot in the process. Thank you.
Thank you very much, Dr. Sridev. It was a pleasure, privilege. Thank you.
Thank you so much. Wow, wonderful. Now, I think I would just 2 hours. Let me take 2 minutes to talk about it. First, Dr. Sanjay, and then to Dr. Sridevi, one by one. Sanjay, wonderful presentation, standing ovation.
Thank you, sir. Thank you, Dr. Nadeem.
That's very kind. If I have to speak it out in Hindi, दिल से पढ़ाया आपने.
Shukriya.
Yes, hey, wonderful. I mean, the calm which you had in when you were teaching shows the depth of knowledge and the control on the subject which you have, and the amount of effort you have taken in trying to choose the case and to present it and to talk on every minor points, and the last part, the last 2 slides as take-home message. That is like, the real most important thing. You have to understand how deep knowledge you have on the subject that you are able to concise that into that and tell us, look, if you get this, probably it's this. So, that much of trying to conclude on that point shows the depth of knowledge I really congratulate you. Wonderfully done. बहुत ही
Thank you,
सुंदर.
Nadeem sir.
Too good.
Thank you.
And I'm so happy that you are here on this channel and trying to teach us. And let me tell you one thing. In India, we don't see so many non-neoplastic lung biopsies. So the experience of most of the people in India with regards non-neoplastic lung biopsies is not so profound as compared to what you see in the West and in Europe and England and in US. And I think as the concept of lung biopsies is growing in India and we are becoming more and more confident, we are going to see more and more of this. This is something which I told Dr. Shukanto also in his last two lectures, that we are going to see more non-neoplastic biopsies, and so we have to get used to that. And you have done a wonderful job. All those people who were here on the Google Meet, in the YouTube, they have really benefited, and this is going to be a YouTube recorded. We'll be uploading the final edited version, and hundreds and hundreds of people all across the globe. We have more than 3,000 people, in the channel, and then there are people who review this. They're going to really see this over time and learn a lot from that. Thank you so much. And we still have 2 more lectures from you, and we really are eagerly waiting for that. We know how much we will learn from that and benefit out of it. Thank you so much.
Thank you.
Coming back
Thank
to
you very much,
Moderator, Dr. Sri Devi. Yeah, thank you. Dr. Sri Devi, you have done a wonderful job. Thank you so much. Just to tell you one thing, Dr. Sri Devi has dedicated her entire life for a very noble cause. She is doing such a wonderful job, which is so different from all of us. I mean, I really would stand up and, do a pranam to her wonderfully. When I hear what you've been doing from people down south, it really, I'm really impressed. Thank you, Sri Devi, for doing so much for those people in the rural area, and for something which God will really bless you with something really good, and I can see that peace in your mind, in your face. Thank you so much for being here on this channel. We are really happy to have you here, and it's a real proud privilege for us to have both of you here. Thank you so much, everybody. I would request you, Dr. Sanjay, to share the PDF of this, on the email. I will share it with all the students. They would really love to, have it. Okay. Finally, Dr. Rajiv Kaushal says, great talk. Thank you so much. With that last talk of comment of Dr. Rajiv Kaushal, I think we'll stop here. 2 hours of solid teaching, and rightly said, we just didn't get bored. It was really wonderful. Wonderfully taught. Thank you so much. Thank you, Sri Devi. God bless you. Thank you, Dr. Jogai.
Thank you very much. Thank you for having me.
Take care.
Thank you.
For Indians, good night, and for you, rest of the good day. Thank you.
Yes, thank you. It's 4 o'clock, 10 past 4. I can start my evening now. Thank you. Bye-bye.
Bye. Take care.
Bye.
Bye.
Thank you. Bye. Bye.